Hey guys, welcome back to another episode of the Making Strides podcast. Unfortunately, we don't have Adam today, my co-host, but we do have a special guest. We have Lisa Zagorski. So she's going to be, she's coming on as one of my physical therapists here at Up and Running Physical Therapy. And so yeah, it's basically we've got 5 PTs now, and we're growing into a pretty awesome team. So super excited every time we have a new one come on. And so I think this is a really good opportunity for her to introduce herself and then for us to just talk some really interesting kind of PT stuff. We're going to not necessarily do Mythbusters, but we're going to surround everything around just things that are outdated or things PTs need to stop telling patients in general. But yeah, Lisa, do you want to just do like a super quick intro about yourself professionally, personally, whatever you want to talk about?
Yeah, well, thanks for having me. I'm excited to talk through some things with you. And come on here in a few weeks at Up and Running. But yeah, I'm a physical therapist in Fort Collins. I moved here about almost 3 years ago now from Austin, Texas. That's where I grew up. Um, and I went to the University of Texas and then went to PT school in Knoxville, Tennessee. Came back to Austin to do my residency there and got my OCS or board certification there. And then came out here to do more fun things. And that has been awesome.
Yeah, that's
So,
awesome. And the
yeah.
OCS is huge too. I looked it up a while ago, and it's really only it's 6% of physical therapists have an OCS. So for people who don't know what that is, it's orthopedic certified specialty. And you did the a residency with that,
Yes.
right? And so I think there's basically like you can't even get it unless right out of school, unless you either practice for 3 years and then pass a rigorous exam. The only way to get it sooner is if you do a 1 year residency, which you did.
Yes. Yes. And it
Awesome.
was definitely rigorous, but totally worth it. I learned a lot and very thankful for it. So,
Yeah,
yeah.
that's awesome. I considered doing some sort of specialty like that at a school, but then the industry really disappointed me in general. So I ended up not doing
Mhm.
that and did something I just settled for a while before I started Up and Running. So it derailed those plans. And then I was also a little bit rubbed the wrong way by I pursued the first thing I pursued was my CSCS, and I passed everything, and um, NSCA didn't actually fulfill my credential because even though I passed everything, the practical exam and the written exam, because I took it too early because I was in a 3+3 program where I finished my
Mhm.
undergrad in like a year early to get into PT school a year early. And they said, even though I was in grad school and like I didn't technically have my diploma in hand yet, it was just how the program worked, that they invalidated my results. So,
Yeah, but it gets away from like, I mean, at the end of the day, you learned all the things, right? So that's
exactly.
where
Yeah.
it gets a little hairy, but
I know. I think in my bio I put like CS, like I passed my CSCS instead of saying I have it. You know what I mean? Semantics.
I mean,
Okay.
that's what matters, right?
Yeah, exactly. Cool. Yeah, you ready to get started with some of these?
Yeah.
Sweet. We have a list here. We're going to go through them. Once again, this is the theme of things PTs need to stop telling patients. Okay. And I know that we have a big runner population listening to this podcast. Almost every single one of these can relates directly to runners. And then when we explain with some examples, we can use runner examples if you want. But okay, the first one is so we're like speaking to the patient here, and this is what we want to stop telling patients. Quote, you need to stop doing enter activity, period. So I don't know how many here like are listening, but can relate to having gone to the doctor and being like, hey, so it hurts when I run, and the doctor being like, well, stop running. And sometimes it's not that aggressive, but sometimes it's like, hey, doctor, I was training for this 100 miler, or
Mhm.
not even a 100 miler, like a 50K or a marathon even. And I started to develop this pain when I was running beyond, when my training got beyond 40 miles per week. And then the doctor saying, well, just don't run that much.
Mhm. So
Yeah.
sad.
What are your thoughts?
Well, and I think you can equate the same thing too with like, oh, it hurts when I squat. okay, well, just don't squat. Well, you can't not squat. Like, so first of all, I'm just frustrated when people say that. Just like as a blanket statement, it's so much more complex than that, right? Let's look at, how you're running or how you're squatting. Like, is there something that, you know, we could modify, or like, can you squat to this depth? Maybe we work there for a little bit. How's your speed? Like, there's just so many other elements than just to blanketly put it out there like, oh, just stop that.
Yeah, there's so many variables. I mean, so to say that to somebody without exploring what are some modifications like of the movement itself? What are
Mhm.
modifications of the speed at which you're doing it, the intensity at which you're doing it, the volume at which you're doing it, but knowing that these are temporary modifications as well and pitching it that way, right? So, as Dan John likes to say, we got to calm shit down before we build shit back up. That's a lot of the time people come to you in the state where they need to, or they come to us in a state where they need to be. Um, their nervous system needs to desensitize, or if there is tissue injury, it just needs some, to kind of progress through some of that initial acute inflammatory phase. But there are definitely things that can be done during that time period that keeps
Mhm.
somebody active and physically prevents unnecessary deadaptation and mentally keeps them
Mhm.
stimulated as well and psychologically.
Big time. I mean, in thinking about like how many patients come in or that I've seen even recently that are like, oh, well, my doctor told me, don't squat or don't lunge like ever again. And, it just goes to the point where like we need to be careful about our language and our words, right? But like everyone can kind of hang on those words. And so I try to even overemphasize like this is just for right now. Like we will definitely progress back up to that if that's the goal. um and these are other things that you can do rather than just avoiding that movement altogether.
Totally.
Yeah.
Awesome. Cool. Let's move on. I'm gonna try and stick us to 2 minutes per topic. And then I'm gonna let you start this next one. So the next one is your enter body part hurts because your enter other body part is weak or whatever. Anything like that. Go for it.
Yes, so there is again just so many elements to that, right? Um, you're you need to be looking at context. You need to look at, okay, so if you're just purely going off of like a manual muscle test, you're not looking at the whole picture, right? And to say like, oh, your glutes are weak and that's causing your pain with running, like that is, in my opinion, almost the easy way out, right? It's not looking, you're not testing that strength in a functional position, looking at other mechanics there, like, and almost like having patients think almost too much about the biomechanical side. We know the research on that. Um, so I tried to phrase it more so as let's look at the whole picture. Um, you might or you could be stronger in certain areas, but it's not just this one muscle that's going to be to blame, right? Um, so that's my initial thoughts without spending too much time on that soapbox. But
Yeah, I think
what?
strength is extremely important for sure. But it is just completely way too reductionist to say that you're in pain because something is weak. And speaking about literature, I mean, there is a fair amount of literature out there, depending on what we're talking about, that there are correlations with something hurting and something being weak. I mean, for sure, but it is still way too reductionist. We have to look at the whole biopsychosocial kind of ecosystem for somebody to really determine their whole pain experience and situation. And so, I mean, yeah, correlation does not equal causation. And so that's the other piece there. I mean, there's actually um, there's some weird correlations out there, and like for example, decreasing number of pirates active pirates with global warming are actually inversely almost exactly correlated. Like stuff like that. It's just stupid stuff. And
Yeah.
so that does not mean that pirates prevent, the existence of pirates prevents global warming. But so it's just way too reductionist. And then we'll just add this straight to the next one because you already hinted at it. But the next one we had listed here is telling a patient your XYZ or body part hurts because just enter any sort of basic biomechanical reason. So for example, with runners, your knee hurts because your running form is off in one specific way. Once again, there are correlations here. Like if somebody is grossly overstriding, which the definition of is probably not the definition that a lot of people probably don't know how to define that, but let's just say it is, they are overstriding. Um, we know that that places quite a bit of extra stress on the knee, but still, like there are many, many more factors here that we need to take into consideration. And saying that does not really help anything,
Mhm.
saying it as a fact like that. Um, but or like you're in pain because your XYZ body part is out of alignment or something. Like half of what people say, or because you have flat feet or whatever. A lot of these things that people say in the biomechanics kind of department for being the cause of dysfunction or pain is actually completely unsubstantiated and just not supported in the literature at all. So, and that's when I get frustrated. But
Yeah.
anyway, I don't know if you have any other thoughts there.
Yeah, and I find this, a little bit trickier because a lot of people want to understand, the physiology, biomechanics behind like why they're having pain, right? And so sometimes they pull up their anatomy, picture and they're like point to where, how this is all, and kind of goes back to what you were saying about the muscle. But it's so much more complex than that. And so I try to, avoid going into that biomechanical lingo, if you will, as much as I can because of that. I feel like all the literature supports not doing that.
Yeah. I think PTs also feel like sometimes they have to sound smart to their patients
Hmm.
and they would rather talk about and try to
Yeah.
explain the anatomy and biomechanics behind why somebody's in pain to a patient who's like a janitor or something. Like, you know what I mean? Or just not, whatever. It doesn't matter what they are, but they're just not in that field at all versus asking them like, but then they'll completely omit asking them like how their home life is and what
Yeah.
other stressors they have in their life. And
Hmm.
those things the literature supports are much more powerful factors in somebody's pain experience than these minute biomechanical things, right?
For sure.
So anyway,
Yes.
cool. Okay, we can move on. Okay, we need to stop telling patients that okay, you need to do enter complicated warm up or enter muscle activation before you do what you want to do.
Yes. And I'd love to know your thoughts on this too. Specifically even like with runners. I feel like I have a lot of runners who will ask me like, "Oh, well, I didn't warm up or I didn't cool down." Um, and really, I would want to dive further into the research on um, what would be supported there. But I typically try to just get people moving and progressively add a little bit more intensity, volume for whatever that functional thing they need to do is. Um, that sets them up for success for that specific movement.
Yeah, absolutely. This is completely going to depend on what somebody is doing. Um, Recreational running, I mean, running his does I mean that's a fine warm up. I mean, running a little easier. Really with anything, unless we're talking about explosive or power kind of activities, doing whatever you're doing but just slightly less intense is fine. Like, how do I warm up for doing like lately I've been really progressing my pull-ups, like adding weight and stuff like that. I don't just jump to adding 25-pound weight on my waist. I will do like a set of, a couple reps of slow controlled body weight pull-ups. And then I put the weight on. You know what I mean? I'm not doing some like rotator cuff or, scapular muscle activation exercise. And same with bench pressing. Like I don't just jump straight into like 80% of one rep max. I will, I'll throw the bar and I'll do a couple reps with the bar and up the weight a little bit. And then with runners, honestly, my favorite warm up with runners is a brisk walk. 5 to 10 minutes of brisk walking. But here's the thing is like most people who have a life are very like they're trying to fit in. They're taking their valuable free time and trying to fit in something that they love. And our job as physical therapists is to help them do it in a safe way, but also just to help them do it. And if they have 1 hour because they have a busy job and a wife and multiple kids, and they have 1 hour to do what they want to do, and you're spending like 20 minutes of that doing exercises that, yeah, maybe there isn't any super solid like evidence in the literature to support like doing it, that's a waste of time, I think.
I agree. I mean,
Yeah.
very frankly, and I think without going too far into like this soapbox, but like people who will do a lot of like static stretching or things like that right before doing XYZ. And they're like, well, should I be doing more stretching? And it does come back to like what your goal is, right? But at the end of the day, I tell people do as much stretching as you feel like you need to be able to do the strengthening or running, it your functional thing. It doesn't have to be like half your time. That's frankly a waste of time. Yeah.
Yeah, for sure. I always tell people too, I'm like, hey, if you enjoy doing that warm up, go for it. You know what I mean? But if like that's your time to do that stuff. But then I have runners who are working 60 hours a week who want to train for a marathon and fit in like 8 to 10 hours of training per week. And I'm like, dude, where are you going to fit that in if you're like warming up for, 20% of that? So I think just helping people organize, especially the endurance athletes, because that is a very time consuming sport. Endurance athletics in general. And so helping them win their time back by shaving the fat of what they don't really need to be doing. What's going to get them to their PR? Literature's, supported answer here is the volume, like getting it in. So if you're able to just run more miles per week in a safe and healthy way, then that is going to get you a better, more successful marathon time than doing like some extensive warm up before every run.
Yeah.
So cool. Sorry, I'm like clearing my throat every minute. Okay. Let's see. Okay, yeah, this one's pretty easy. This will be quick and easy, but enter any exercise is inherently bad for you. So this is less of like, I guess we're transitioning from things we directly say to patients to just like topics, but like saying that an exercise of any kind is just inherently a bad exercise. It's bad for you. I think PTs need to stop saying that.
I would agree. I mean, it's too overgeneralized, right? Like, let's look at how you're doing that movement. Let's look at what your goal is. Maybe it's more that to get to where your goal is, you could be doing other things that might help more. But I think it comes back to the language there and how we're wording it. And then the patient is like, well, I'm just doing everything wrong. And, that's not necessarily the goal of what we want to be, we want to be empowering our patients and, giving them more resources, right?
Yeah. I think most patients have some level of kinesiophobia. And so by saying that an exercise is bad for you and adding that like nocivic effect of that, it just worsens it. And just so I know there's not going to be like not everyone's a PT who's listening. So kinesiophobia meaning fear of movement. And even if it's not an actual fear of movement, but like a subconscious, the fear avoidance belief with certain movements because of a pain experience from an injury, it happens. Almost everybody with an injury has some form of it. And then nocebo, meaning like it's the opposite of placebo. So if a placebo is you perceive something to be good that isn't actually good, the physiologic effect is likely good. If you nocebo is if you perceive something to be bad, like an exercise, even though it isn't actually bad, it is more likely to have a bad physiologic experience with you. So it's psychological trickery. And so we can definitely reduce a lot of that by just not saying those types of things and really just instead looking at like, hey, you're not injured because you squat knees past toes or do a deadlift with a rounded back. You're injured because you did too much too soon, most likely. You just progressed too quickly. You overloaded what your tissues were capable of. They were adapting in that direction, but we just forced it a little bit too quickly. Um, anyway, so it's my
Yeah.
soapbox.
It's more of a, let's look at how you're doing said movement. Um, and sometimes, it's actually just improving their confidence with that movement. Maybe, like you mentioned with your example, at a lighter load or, at a different depth, preparing them for that type of load or movement, if that's what the goal is.
Absolutely. 100%. The next one is eccentrics, or like eccentrics only for tendinopathy. I just think that this one and a couple of other, so we can just lump them together for time's sake, but so eccentrics only for tendon issues, and then modalities and passive treatments in general. All of that stuff is very like 1990s, early 2000s style PT treatment, where you go into a clinic and they put you on heat and heat and stim or whatever, or maybe just heat, and then they do ultrasound, and then they get you up to do maybe they do a little massage, and then they get you up to do some like heel, like if for an Achilles issue, maybe they have you do like heel drops, just where you're literally lowering your heel off of a step or something like that, and then you're using the other leg to get yourself back to the upright or the higher starting position, so you're not actually doing like the upward movement actively. um, there was some literature, and there still is literature that supports that that can be very effective for tendinopathy, but it's not always the best. And a lot of times we just get more, we just get better, a better effect from doing the concentric or upward movement and that downward movement, or I guess the shortening movement and the lengthening movement, to be more accurate. And so that's just it's just old school thinking. So I think the topic of this one was just like there are some things that are clearly debunked in the literature and have been for decades. Like another example is like using motion control or stability shoes in runners. Like stuff like that has been debunked for decades, yet we still hear it over and over and over.
Well, and I think what you mentioned about the word only, right? Rarely is it going to be, we're only going to do this, right? It's, and you could even lump this like passive treatments, massage or even dry needling, like only that would be doing a disservice to your patients, right? Um, Specifically with dry needling, all the research, well, not all, most of the research is going to be combining that with exercise, right? To get the most progressive improvements. And so if you think about like passive modalities or passive treatment, I mean, there's a time and place for it, but usually it's at the beginning and it's when we're calming things down more so that you can do all these other things like exercise and what you are coming in for in the first place, right? I could talk
Totally.
about that all day.
Yeah.
That whole
Yeah, I mean,
bunch
that's
of
another thing that should be on here though. Yeah, like passive only treatments in general. Yeah. Um, but you mentioned the dry needling, and that's the next one. The next topic is like dry needling with, we have to stop saying like dry needling will fix this,
Mhm.
to patients, because it's not the case. I mean, it's just, it creates a window of opportunity for some other change. It like I sometimes explain it to patients too. I'm like, I can accomplish with a needle in like 2 minutes what maybe like a deep tissue massage for 20 minutes can accomplish. Which would you rather have? Because the first option with needling saves like 18 minutes of exercise. that combined with the dry needling is going to have a profound effect over the massage alone.
Totally agree. I actually phrase it very similarly to my patients, um, and that's a lot of the feedback is like patients literally saying that felt, that was 2 or 3 minutes and it felt like a 90-minute massage, right? And so it is tempting because it does like feel really good, and you feel really good sometimes even for like a few days, but it's not, well, and it depends on what the goal is, right? But rarely, uh, I would say, would that be the only thing you need by any
Yeah.
means.
Yep.
Yeah.
As in all things.
Yes.
um, okay. Yeah. And then the last one we had written was my favorite. And this is, I'll let you go first though. Um, PTs just not, PTs need to stop not prescribing intensity with their exercise. So for example, if you go to PT and they're like, do this exercise, this exercise, this exercise, you're going to do them this many times per week. That is the frequency. Or yeah, for this many weeks, that's the duration. But then like and with this much weight and this many sets and reps and stuff like that, right? That's more of the prescription. But the part of the prescription that is missing most of the time, but maybe the most powerful, is the intensity, which a lot of times is driven by someone's pain level, right? Because if you could have somebody with a reactive tendinopathy, right, where they are like their tendon, like their Achilles tendon is so reactive that it's just getting pissed off with anything you throw at it. It needs to calm down first. And that person, like progressive overload may not be, that's going to be more of a graded exposure approach. But with somebody who's got like that chronic Achilles tendinopathy, and they're just like, oh yeah, their PT's like, go do 3 sets of 10 heel raises or heel drops, and it'll be fine. And they don't talk about the progressive overload piece. But go for it before I go too far.
Yeah. I mean, again, there's just so many facets here, right? And so many questions that need to be asked that I find aren't asked. Like, and it will depend on, what is going on and what that patient's, irritability, severity of their pain is, right? Um, and if it is more of like that tendinopathy versus something else, and what the goals are, right? um if you want to be back squatting 150 pounds, and right now you can only do a body weight squat, yeah, we're going to be definitely progressively ramping up that intensity. But to start, where do we start? Yeah, that's where 3 sets of 10 body weight, how are you doing after you do that? Are you wiped? When was the last time you did this? Like, there's just so many variables there. Um, and it does require asking certain questions that I find just aren't asked. And then people do 3 sets of 10 of body weight, or like 10 pounds for like with a bridge for what, 6 weeks. And then they're like, well, I'm not better. I'm like, well, yeah, I wouldn't expect you to be at that point. And so my big thing in terms of that topic would be, are you asking the right questions?
Yeah, yeah, totally. Yeah, but I mean, every single one of my patients gets RPE prescribed with their exercises, and we talk about intensity, right? And so RPE standing for rating of perceived exertion. In general, when we're talking about strength training, it's inversely correlated with reps in reserve. So for example, an 8 out of 10 RPE is equivalent to doing a set where you reach failure or form failure. If you were to so basically 8 out of 10, you have two more, you would finish the set and only have 2 reps in reserve till form failure or failure of that exercise. So if I say to my patient, I want you to do 3 sets of 10 at RPE 8, then I'm not prescribing a weight for them to do the exercise with, because that is the variable. That is the variable that we are changing every set in order to reach the actual desired goal of the intensity, which is 2 reps in reserve at the end of the set. Now, here's the other issue though, is a lot of patients don't actually know what that feels like to have 2 reps in reserve at the end of every set. So I usually don't do this for a couple of weeks because otherwise it can be a little bit too much shock to the system. But let's just say I'm doing like a split squat with somebody. I'll do what I call intensity anchoring, where we'll anchor their intensity, right? And so what I'll say is, hey, you've been doing the split squats a couple of weeks. What I want you to do is, and your pain's been good, we're looking to progress things. The more intensity we get, the better adaptation and preparation for the activity we're returning to. So I want you to go over and grab a weight that you can only do 10 times. Nice slow reps. You can only do it 10 times. Like if somebody put a gun to your head, you can only do it 10 times. You couldn't do it anymore after that. And I have them go till 10. When they hit 10, almost like 99.9% of the time, I say, keep going.
Yeah.
And I trick them. It's a surprise. They're like, what? And I say, keep going. I usually let them do like 2 more reps and then I stop. And then I ask them, be honest with me, gun to your head. How many more reps could you have done if you had to? And they usually say like 5+. I kid you not. And then I give them a couple of minutes and I say, okay, we're going to try again. Now go pick a weight using what you just learned that you can truly only do 10 times. And I promise, and I usually tell them that this time around, I tell them, I'm not going to make you go to 12 this time, but just like really try hard to pick the right weight. And most people get pretty dang close that second time. But a lot of people just don't know what that feels like.
Yeah. And I will say, like, especially for um, endurance athletes, that can be a little bit harder to perceive because you're just so used to like saving up, right?
Mhm.
I know, like, transitioning my background personally, I've always been a runner, and I've been getting more over the past few years into more strength training. And that was like one of the hardest things for me. I was like, you know, I'm used to kind of keeping some in the tank. And what I found was I really wasn't pushing myself. And so I try to, really challenge patients with that too, which as the therapist can look like, okay, we're going to do first 2 sets for 5 reps, pretty heavy. The third set, I want you to try and do, as many as you can up to like 15, let's say. And just even like learning in that set or series of sets, you just get more feedback on how much you can actually do, right?
Mhm.
And how much you are actually saving in the tank.
Yeah.
And then, using that as that baseline and giving them tools on how to start to adjust that intensity, engage that on their own.
Yeah, absolutely. I think you hit the nail on the head though with the runners and then not being strength athletes at all. But I think it's funny because runners love to suffer, but they don't suffer at all, and they like don't tolerate any suffering like in the weight room, which is really funny. I was a strength athlete before I was a runner, so I don't have that problem. But yeah.
Very nice.
Anyway, yeah, but I try, but it's really rewarding for me when I get runners who are not like me to really step outside their comfort zone. It's so empowering for them to just to find out that they can be strong and robust without sacrificing their running, and actually it enhances their running. And so, and their ability to be a human being in general and like do normal things without getting injured, like helping your friends move a couch or whatever. Um,
Yeah.
but anyway, cool. I can go on and on and on and on, but it's pretty much all I wanted to cover today. We hit all of our topics. Did you have anything else you wanted to bring up?
No, I mean, those are all things I'm really passionate about. So I'm glad we got to discuss them a little bit more.
Awesome. Yeah, so just wrapping up, Lisa, thanks for coming on and talking about this stuff. We can always do more in the future. For anybody who's listening, who's interested in working with us, there's like a little, if you've never listened to the very end of the podcast, there's like a special offer for folks who want to come in for the first time. If you're interested in working with Lisa, definitely stick around to hear that offer. And then that's pretty much it. Otherwise, you can always reach out and ask any questions at any time. Cool.
Yeah.
Well, we do this corny thing, Adam and I, where we say, okay, now go make some strides, because Making Strides podcast. Anyway,
Yeah.
but anyway, we'll count that as me saying it and we'll just say bye. Okay, bye, guys.
All right.